And like Dr. Phillips said, I'm Susan Lebersky. I've been with the gastroenterology group in Naples 22 years, and I have a fair number of patients with inflammatory bowel disease. A couple of them are here today. I won't say who they are because of HIPAA violations, but anyway, thank you all for coming out today. And you know, having inflammatory bowel disease, you worry every day. Are my symptoms going to flare? Am I going to be close to a bathroom? For kids, it's, oh my goodness, I have a big test in school. What if I got to go poop in the middle of everything? And how am I going to adjust and how am I going to cope? And everybody knows when you're having a flare of your inflammatory bowel disease, you're as sick as a dog. And fortunately, my puppy Skipper, that was after she was spayed, but I think that's the typical feeling how people feel when they are having a flare, their IBD. They want to lay on the couch, put their head down, and sometimes just want to cry. So everybody here who has IBD or has a family member or friend with IBD knows what a flare is. It's a reappearance of symptoms. You have frequent urgent bowel movements and diarrhea, you have cramps, you have gas, you're pooping blood, you have abdominal pain. Overall, you just don't feel well. Some people can experience fatigue, they lose weight, they have a lack of appetite. And going back to one of our earlier speakers today, what was one of the craziest things somebody said to an IBD patient? One of my roommates in medical school, she had Crohn's disease, and that was in the days where there was only 3 treatments for Crohn's. It was the 3 S's, sulfasalazine, steroids, and surgery. So she went through a lot of crazy days, and I remember one time she had gone through a horrible flare, and being her roommate, we all knew how long she was in the bathroom. And she lost a ton of weight, probably 20, 30 pounds. I mean, she was a tiny woman to begin with, and she got even tinier. And someone else said, gee, I wish I had that disease so I could be skinny like her. I thought, oh my God, no you don't. And sometimes when you're having a flare, you feel like you're drowning. And that's my husband, and he's supporting our other German Shepherd, Paulo, who does not like to swim. And I just want you to know that you have life rafts, you have life preservers, and you have people around you that are going to help support you through the flares and help you get on and get on to your next day. Now, probably the most common reason why people have a flare of their inflammatory bowel disease that I've seen in my practice in the last 26 years is that you start feeling well on your medication, and then you start skipping some doses. Or, you know, your insurance changes and all of a sudden your injectable is no longer covered and you're on a new insurance and it has to get pre-authorized and you miss a dose or 2 or 3 and all of a sudden you're feeling bad again. And that's probably the #1 reason. Just a little asterisk above inflammatory or non-steroidal anti-inflammatory drugs, things like ibuprofen. Everybody knows they're great pain relievers. And if you have any of the arthritic complaints that go along with inflammatory bowel disease, or young ladies when they're having their menstrual periods, you know, they all know you've got cramps, you don't feel right, and nothing works as good as a non-steroidal anti-inflammatory drug. But if you take them in real high doses, or you need to take them all the time, unfortunately it can flare your inflammatory bowel disease. And there's actually some evidence that non-steroidal anti-inflammatory drugs can actually cause colitis and inflammation in the colon that's not dissimilar to Crohn's and UC. So it's important to know that maybe a limited dose, one Advil is not going to put you in a flare. But if you need to take these medicines long term, it may. Dr. Phillips mentioned antibiotics, which I'll go through a little bit more. I'll give you my speech on smoking in a few minutes. Stress, a common problem. And Dr. Hara did an excellent presentation on food, so I may skip over that since the day is getting long. But you know, when you're having a flare of your IBD, it's like your bowels are in an uproar. They're fighting each other. And actually, I did take that photo in Africa when I was on a trip a couple of years ago. And I thought that was pretty awesome that the 2 zebra were fighting with each other. And it does remind me of all my patients who say what their guts feel like when they're having a flare of their IBD. Like I said, non-steroidal anti-inflammatory drugs. Aspirin is common. People who have heart disease and need to be on high-dose aspirin, and suddenly they've had a heart attack and they've had stents, and their cardiologist tells them, you're going to die if you stop your aspirin. Sometimes that can cause a flare. Like I said, the other 2 common over-the-counter, naproxen and ibuprofen. Again, small doses probably won't hurt you. Long-term use may be a problem. Antibiotics. I've heard Dr. Phillips give a lovely lecture on the microbiome, and maybe perhaps the microbiome, the bacteria that live in our GI tracts. Maybe that could be a topic for next year's IBD conference. But you know, we all have a whole, we're like the solar system, and all the inhabitants of the solar system are the bacteria that live in our GI tract. And what we ingest and what we take, specifically antibiotics, can alter what's going on in our intestines. And when I have a patient that comes in and says, I'm having a flare of my IBD and I'm having diarrhea, one of the first questions I ask is, are you on a new medication? Have you had a recent antibiotic? Because obviously the most serious potential alteration in the gut microbiome is the flare of C. difficile. And as you know, the treatment of C. difficile is often very long and complicated, and so that's something important to know. So if you do need to take an antibiotic for another reason, you've got a big staph infection on your leg and something else, and you need to be on long-term antibiotics, it's important to talk to your gastroenterologist about what you need to do to try to help prevent a flare of your inflammatory bowel disease. Smoking. Smoking is bad. I don't know why anyone would smoke. It causes gray hair and wrinkles, and it ages you, and I won't talk about lung cancer or heart disease or any of the other bad things, plus it's very expensive. And probably the first thing I do in my patients who have already had established diagnosis of Crohn's disease and they smoke is I tell them to quit. And I try and I try and I try. And actually last year one of my long-term patients came in, she was very proud, both she and her husband smoked, and she came in and she said, here, this is my last cigarette, my last pack of cigarettes. Our New Year's resolution was to quit smoking, and she finally did. And Dr. Phillips walked in my office one day. He said, why do you have a half-packed smoked pack of cigarettes on your counter? I said, because I'm very proud of my patient, that's why. But it is important to quit smoking, because definitely smoking can cause flares of Crohn's disease. Now, the flip side of the coin is that patients with ulcerative colitis may actually have some improvement in their symptoms from the use of tobacco and nicotine. And patients who are current smokers who have ulcerative colitis, they stop smoking, tend to have flares of their ulcerative colitis. That, however, the corollary of all that is that I do not encourage patients who do not smoke with ulcerative colitis to start taking up smoking. And again, I could tell you a story of, I've been doing this a long time, I've seen a lot of patients. And I had a patient who, years ago, when, again, the only treatments for inflammatory bowel disease were the 3 S's, steroids, sulfasalazine, and surgery. His doctor up north, he was an older gentleman, he was probably in his, well, he was probably about 75. His doctor up north told him years ago if he took up smoking, it would cure his ulcerative colitis. And believe it or not, this guy was a 3-pack-a-day smoker, hadn't had a flare in 20 years, was on no medications, was one of our seasonal visitors, came down to see me one year and he said, oh, my ulcerative colitis is doing great. I haven't pooped any blood, I haven't this, I'm here for my colonoscopy. And as he's sitting there, he starts coughing and coughing, and I said, what's going on with your cough? Thinking maybe you had a cold or something like that, purely incidental. And he said, yeah, I've had this kind of nagging cough for the last couple of weeks. I don't know what's going on. I sent him for a chest x-ray, and unfortunately, he shortly thereafter died from his lung cancer. So, important thing to note is don't smoke. There had been studies years ago trying to use topical nicotine to try to control the symptoms of inflammatory bowel disease. And again, those studies never really showed any improvement in people who had ulcerative colitis if they used nicotine patches. I hope I got my point across about smoking. I was also in, that picture was taken by me in Kenya 2 years ago. Now, stress. If I could write a prescription for you to have a stress-free life, I'd be the richest person in the universe, I'll tell you. And stress does impact your inflammatory bowel disease. Does it cause inflammatory bowel disease? No. But anybody, even people who have irritable bowel, which is obviously clearly a different animal than inflammatory bowel disease, will tell you, in a stressful situation, your guts are going to act up and you're going to have problems. I'll go back to my roommate in medical school. When we had midterms and finals, she lived in the bathroom. and she didn't want to be taken to the hospital, and she didn't want to be put on high-dose steroids because she hated being on high-dose steroids, having the moon faces, being sick. And my other roommate and I used to bring her tea and chicken broth in the bathroom while she was studying for her exams. I mean, she successfully graduated from medical school. I haven't heard from her in a long time, but she eventually did well. But it's important to note that stress can impact your inflammatory bowel disease. And I think all those stress-releasing exercises we did this morning were kind of fun. Of course, I did think the bubbles were holy water, which I thought, why didn't I think of that? Just start sprinkling on its own vacation. And again, Dr. Hard just did a great talk on food. And it's important to note, if you're having a flare and you don't feel well, number one, don't let yourself get dehydrated. Don't completely put yourself nothing by mouth. If you really can't keep down liquids, then you should probably be in the hospital. Really try to keep up the hydration, nutritious liquids. You know, there's all kinds of simple over-the-counter things, Boost and Ensure, and there's some clear formulas of that, so if you can't tolerate the lactose, but try to keep yourself hydrated. And as Dr. Har also mentioned, you know, the foods you eat may impact some of the symptoms you have, but may not necessarily be a flare of your inflammatory bowel disease. And hopefully I'm not boring you by reliving some of these slides here. And again, foods to avoid. Going to the question about FODMAP, I can tell you things that are high FODMAP: broccoli, cabbage. Don't drink a lot of caffeine. Caffeine's not a FODMAP, but don't eat a lot of greasy, fatty foods. All the things I like to eat, don't eat them when you're having a flare of your inflammatory bowel disease. And simple things that sometimes people don't think about. If you're in the bathroom, you're having a flare, you're pooping a lot, very simple maneuver. Get some baby wipes for sensitive skin instead of using toilet paper. And carry some in your purse or in your pocket, so if you are someplace and you have to use a restroom, I mean, there's nothing worse than using harsh toilet paper in a public restroom when your bottom is sore. And there are some perianal cleaning products, things to keep your bottom clean and dry. And there are some over-the-counter creams and salves that are also very helpful, just to keep some of the irritation around your anal canal kind of not so uncomfortable. Soaking in a warm tub of water may be helpful, but avoid things like bubble baths and bath gels and things like that if you're going to be soaking in a tub. And if you're having just a minor flare, you're having a day that's just not a good day, over-the-counter medications can often be helpful, as Dr. Phillips said, things like Imodium and even kaopectate, stuff like that, to just kind of slow things down a little bit. Make sure when you're having a flare you get plenty of rest. You don't want to stress yourself out more by being sleep deprived. But this is the dawn of some new treatments for inflammatory bowel disease. I mean, over the course of my career, I've been happy to see that it isn't just sulfasalazine, steroids, and surgery for the treatment of inflammatory bowel disease. And we're really at the point in time where we're really trying to personalize how we medicate each and every one of our patients. And when we have somebody who has a new onset of inflammatory bowel disease, or they're having a flare of their inflammatory bowel disease, you really want to kind of risk stratify how somebody is. Are they a little sick, or are they really sick? And so sometimes, even though you may have just had blood work last week, you may have had some other studies done just 6 months or a year ago, sometimes some of the studies do need to be repeated just to see how bad you really are, so we know what the next step is going to be. Because if you have, just some minor symptoms, sometimes increasing the dose of your 5-ASA product, your mesalamine product, or putting you on a low-dose steroid for a short period of time may be all you need to get you over that course. But sometimes, if you really are sick, or if you're a patient who is in a new diagnosis and you have a lot of symptoms, and we find that you have a lot of inflammation within the GI tract, those are the patients that we may want to start the anti-TNF therapy on an earlier basis. You don't want to be like an ostrich. They really don't hide their heads in the sand, and you shouldn't either. When you're having a flare, you really should seek your medical attention. I think Dr. Phillips used this slide about the key points to remember. The anti-TNF and the anti-integralin therapies are really the most effective therapies used to treat inflammatory bowel disease. And patients with inflammatory bowel disease really don't need to be hospitalized all the time as they were 20 and 30 years ago. I mean, it's a pretty rare occasion now where we have to hospitalize somebody because of a flare of their IBD. And we really need to be very specific on who we're going to start on these medications, because if you have active inflammatory bowel disease and you're sick, we want to be sure that we're putting you on the right medication, because again, there are risks and benefits involved. And we want to make sure that we address all the potential risks. But flip side of the coin is, if we know the medication is going to work and we know you're feeling better, and we keep you out of the hospital and keep you active and productive, then the risks of the medications are really worth the benefit. Again, I like to tell patient stories. I have another patient who really did not want to. She'd been on steroids. She had been on a mesalamine product for years and years. She's had Crohn's disease since she was 20 years old. She's the same age as me, so she's in her mid-50s. And about 5-6 years ago, even though I know she was having a flare and I know she was really sick, and I was begging her to please consider going on an anti-TNF regimen, and she had a lot of fears about going on these medications, and unfortunately she then developed a fistula and an abscess, and she ended up having extensive small bowel surgery. And post-operatively, the surgeon told me, she still has a lot of Crohn's disease going on in there. She's going to need to be on medications for the rest of her life. I mean, it's not like I cured the problem. I just took care of the big problem at hand with the fistula and the abscess. And this patient comes to see me 3 times a year. Every time she comes in, she says, "Can I please stop my anti-TNF? I feel great." And I say, no, anti-TNF is why you feel great, and you need to continue it. And we have the same discussion. Even when I see your name on my list of patients, I'm going to say, okay, let me practice again. No, you need to stay on your medication. It's that important. The risks are definitely worth the benefits. This is kind of so again, important component. If somebody's just having a bad day, that's different than when you're having a lot of inflammation. And those are the patients who have a lot of inflammation. They're having a bad flare. It's nothing minor. It's nothing that gets better in a day or two. These are the patients, if you have not been on an anti-TNF or an anti-integrin therapy, we need to consider. And there's a lot of medications out there now: infliximab, adalimumab, certuzumab, and golimumab. And there are patients that there are some pros and cons in who we can use them to. Some of the meds are only approved for ulcerative colitis. Some are approved for both ulcerative colitis and Crohn's disease. Infliximab, which was the first of all the mAbs out there, was really quite a boon to therapy in severely ill hospitalized patients many years ago, where we used to use some of the other agents that Dr. Phillips had mentioned, where it really kind of turned a lot of people around. All these medications, for those who are worried, if they're a young lady, most of them are safe in pregnancy, and we do encourage patients who are pregnant to stay on their medications. It's really, really critical. The healthier the mother is, the healthier the baby is, and although there's a lot of people who worry about that sort of thing, it really is important that you need to keep your bowel disease under control. And these are natalizumab is very rarely used because of some severe side effects. And the vedolizumab is relatively new, and I've used it on a couple of patients, and I've seen some good results in the anti-integrin therapy. There are some contraindications to using the biologics. If you have tuberculosis, if you have chronic hepatitis B, if you have HIV, if you have an ongoing serious infection from other sources, these are people where you can't use them. There have been some patients that, if you have known congestive heart failure, heart disease, they may exacerbate that. It's important to know. It may exacerbate certain neurologic diseases. And again, there is the risk for lymphoma in patients who use these drugs. There are some patients that really do not want to give consent to these drugs, and it's really kind of unfortunate because it really does limit how you do treat the patients in the long run. And the risks of steroids, I mean, steroids are good for what they're good for, but they're bad for every other part of your body. And steroids are good in the short run, but not good in the long run. And so I really try to, when I have patients who I really have a hard time trying to wean them off a short course of steroids, I really start pushing the door to consider a biologic therapy. That's just some more risks of anti-TNF, just more other infections that you need to be aware of. skip that one. Hopefully I'm not leaving you scratching your head as I'm going through some of these quickly. The immunomodulators, as Dr. Phillips also mentioned, 6-MP and azathioprine have been around for 50 or more years. Prior to the onset of the use of the anti-TNFs and anti-integralins, these medications were often used as a substitute for steroids. They're slow in coming on to acting, they're slow in onset of action, but they really do maintain remission in a lot of patients. And again, there are some potential risks involved. There are things you need to monitor, especially the white blood cell count and your liver enzymes. There are some people that don't tolerate them because it can cause pancreatitis and some other abnormalities. And there, again, with these drugs, there also is a risk of developing lymphoma, increasing your risk of that. The nice thing about the immunomodulators is that they're oral medication, not an injectable. They've been around for forever. They're not as expensive, but again, risks and benefits to using both agents. There's a school of thought that if you use an immunomodulator with an anti-TNF and an anti-integralin, that you may actually decrease the risk of developing tolerance to the anti-TNF. So some professors and some universities will push the idea of putting patients on both drugs right from the start to control their inflammatory bowel disease. There is some evidence that using two agents together are better than one. I have a hard enough time convincing many of my patients to take one of the medicines and not both, that I'm happy if they agree to try at least one of the medications that I'm pushing for. Although, and there has been some evidence that it may increase the risk of certain lymphomas when you use the two drugs together. But the flip side of the coin is you may tolerate your medical regimen longer and keep you in remission longer and keep you feeling better longer. Yes, ma'am.
A lay person, TNF.
That seems like Remicade and Humira, Cimzia, those the injectable medications that are used for inflammatory bowel disease.
What does this stand for?
Anti-tumor necrosis factor alpha. Tumor necrosis factor alpha is a part of your white blood cell system that is the thing that leads your white blood cells, that highway Dr. Phillips was talking about earlier today, where your white blood cells go and attack a certain part of your body. The anti-TNFs, it's just part of that white blood cell system that we are now blocking that response so that the white blood cells don't attack the bowels and cause the inflammation. Does that answer the question?
Mm-hmm.
Okay, good. Back to my flamingo. This was in Busch Gardens. That wasn't any place exotic, but our goal of therapy is to try to keep you in the pink, and I do like flamingos. And as you can see, we want to keep everybody smiling and happy, not the sick dog, not the dog that needs a little life preserver. We want to be happy and healthy. And I know I've kind of rushed through some of these slides, but we've had a long morning, and I think it's time for us to consider going home. So I'll be open to any questions, or if you, I don't know, Jamie, if you want to get the panel up here, or what you would like to do.
Yeah, why don't we go ahead with that? So we're going to open it up and have all our speakers come up, and you can ask questions. We'll open it up for about 10 to 15 minutes to see if anyone has questions that you'd like to ask them as a group or individually. And just as a reminder, while you're sitting here, your evaluation form, if you could please complete that before we leave today and just give it to myself or put it on the table out front. So we'll go ahead and field some questions. If anyone wants to start.
Well, I'm going to ask Dr. Phillips a question, even though we've been in practice for 20 years plus together. When do you choose to start a patient on an injectable medication for their inflammatory bowel disease over the course of their treatment? Somebody who's been on a phytosaline product, they're a seasonal resident, they just moved to Southwest Florida, and now they're having a flare of their ulcerative colitis.
Yeah, it strikes a particular approach now that we're taking in inflammatory bowel disease. For 50 years, it's been good enough to make the person feel better. to get rid of the diarrhea, get rid of the bloating so they can eat again. But now the notion is, well, we have a means now of being able to put people in remission, so,
And heal the tissue.
and heal the tissue. So now the goal is, hey, let's try to reduce the inflammation and get it down to normal, so it doesn't progress into scar tissue or blockage or intractable symptoms. And so now the notion is to risk stratify quickly, see whether an individual has a more advanced disease, and if they have more advanced disease based on their symptoms and endoscopic evaluation, the notion is, rather than fussing around with medications that are not very effective and won't achieve that goal, is to go rapidly to our very best medications and get the individual who has a great deal of inflammation, get that under control, get it under control quickly, so we can get them back to normal quickly. So by risk stratifying a person, determining whether they have a moderate to severe disease, that's what really determines whether to proceed on with a biologic drug in a rapid fashion. Now, steroids still have a role in that context as a stepping stone to more effective therapy, but that's pretty clear now what the role of steroids is just to act as a stepping stone, a brief stop to control the symptoms until we have more effective means of controlling the symptoms and the inflammation. And so that's the overriding strategy, that and we're finding that it's very, very effective if you do that early, if you do it quickly, rather than stretching this out over months or years before you make that decision.
I agree.
So, and then, but the trouble is that individuals will resist that, and there's this notion that if I can just find the right food, or avoid the right food, or the right combinations of food, I will hit on the right solution, and then I'll put myself back to normal. And it just, I think Dr. Hara showed pretty clearly that there is just no data or scientific basis to believe that food will control inflammation and cure you or put you in remission. It may make you feel better, but it won't cure you. And and it won't put you in remission. I say cure, that's not quite the word we should use. Put you in remission is the more proper term, because we get the situation where people feel well, and now on the flip side on biologics for a number of months or a year, and then I'm cured, I ate the right food. It's not your stinking drug, Dr. Lebersky, it's my food program that I got to, and now I'm going to test it out. When you take someone with severe disease, moderate severe disease, that have been on a biologic, and they stop it, 2/3 of them relapse in a year's time, reliably. And you may not get them back under control the next time around. So that's a long-winded answer.
I just saw a patient the other day, and this is something that we see in Naples, is the seasonal person.
Yes.
That has a GI up north, then a GI down here. And this person had been diagnosed with ulcerative colitis since age 8 years old. And he told me it was very minor, very minor. He was only taking, he had only been prescribed Buceris once and had been on no other medication, doing very well. Also had been diagnosed with irritable bowel syndrome. And his doctor up north has increased his clonazepam and medication. But I reviewed his colonoscopy report from March of last year, and it had moderate to severe disease on the left side of his colon. And I had told him, you were actually prescribed Lialda and Buceris. He was like, no, but I didn't start that. And I feel so much better after increasing the clonazepam. So it was a conversation that took over, like it was like 45 minutes, me showing him the pictures, showing him the pathology, and understanding that he may not listen exactly or take my advice. I knew that. He had seen his doctor up north, had a relationship with that doctor. And I just told him, this is my recommendation. You can follow up and ask your primary GI up north what you want to do. But at least I showed him the pictures, the pathology, and told him, your disease is not as mild as you think. It's moderate to severe, based on the pathology, based on the endoscopic findings. And, he at least appreciated the information. I'm pretty sure he's not going to you
Come
know.
back to see you again.
Right, he probably won't come back to see me because I'm recommending medication, but, it's going back to what patient's symptoms, he has irritable bowel syndrome, all these things, he says, I'm under a lot of stress, but, the goal now in inflammatory bowel disease is endoscopic mucosal healing. So, that's something that, I think patients, sometimes they may feel pretty good, but if their colon is not looking good, it's not up in control, it's really just not.
And just to echo